could, if you like, think about what I'm going to say, which is going to be based on the evidence that leads to a changed view of how to treat progressive MS. Not that much, but it's going to be therapeutic evidence that leads one to that conclusion. We've had a great introduction to this from Gabrielle De Luca earlier, and Gavin, and to a lesser extent Klaus, but I want you to view this talk from that point of view. And I could subtitle it along the lines that there are none so blind as those that cannot see. And that, I think, will become apparent as I move on. This is my disclosures. Most of the current therapeutic pharmaceutical companies have given me support from time to time. I like to think in this regard there is safety in numbers, so that I can't be accused of favouring any one of them. So this is the outline that I want to talk about. So what is progressive MS, and are progressive phenotypes useful? Treatment of progressive MS, and a number of points there, and then the perspective. Where have we got to? What do we need? And what should we do? So progressive MS, as everybody knows, means different things to different people. Clinicians have one view, the neurologists, MSs, neurorehabilitationists, MS nurses all have a different view. MR imaging people have a view of atrophy. Pathologists from Dr. De Luca, axonal injury, glial activation in injury, axonal loss. The epidemiologists have another view. But people with MS have an underlying fear of worsening disability, loss of independence, and the social consequences thereof. So if you think about that, that's what should be driving us in terms of this change in approach. So what is it? It's defined loosely as worsening disability in the absence of relapse, or MRI-defined inflammatory lesions, new or enlarged, which is maintained for a period of time. And it's different from relapse-mediated worsening. It does have something mystical about it. People are attracted to it because it's mysterious. We don't really know yet what fully underlies it, but I think this is going to change. But that it emerges over time. It's very difficult to define exactly when this commences, and I think you'll see that it probably doesn't matter too much. Looking at the diagnostic criteria, and the one that's used for primary progressive MS, a year's disability progression, retrospectively or prospectively, and independent of clinical relapses. Plus 2 of the following criteria: 1 or more T2 hyperintense lesion, characteristic of MS in 1 or more of the characteristic regions. 2 or more T2 hyperintense lesions in the spinal cord. The presence of CSF-specific oligoclonal bands. And like the latest 2017 criteria for relapsing disease, you're allowed to include symptomatic and asymptomatic lesions in the count. And I say all these things because this is symptomatic of part of the problem that we face, that people have had to define these things so carefully that we think they're rules that we have to follow, and we tend to be a little blinded to the problem, and that is what's happening to the patient. Secondary progressive MS is similar. There's no good, satisfactory, standardised definition. Fred Lublin defined as progressive disability in 1 or more functional systems after relapse or relapses. Arguably, the best definition is that by Lorschreider in 2016, and they used MS-based case material, but even that is not a simple definition. It includes 3 different strata looking at the progression magnitude. So an increase in EDSS by 1.5 points if the last EDSS before conversion to secondary progressive MS was 0, and so on. These are convoluted and difficult things to do when actually getting an accurate measure of the EDS score is not without difficulty. So, and the other things to say about it is retrospective, it overlaps with relapsing disease, and it's unfortunately led to an artificial segregation of treatment modalities available. Have a look at these things here. This is relapsing. This is a very nice pictorial representation, if you like, of secondary progressive MS and primary progressive MS, and it comes from the National Multiple Sclerosis Society. But here, you enter into progressive MS if you don't have a relapse. If you're fortunate enough to have a relapse, you're classed as relapsing disease and you get access to treatment, like these people. But if you don't have one, you go out to here when you've got all that accumulated injury lying in the central nervous system, then you might have a relapse and you might be allowed to have a treatment because you're relapsing. So it's really a difficult problem, but you have to view it as one that has arisen from the way the understanding of the disease has evolved from clinical features to what we have nowadays. I'm not going to show that earlier diagram which we had that Mark Friedman prepared, looking at the course of MS related to pathologies, but rather just to again highlight the fact that there's an underlying pathophysiological basis is what we should be looking at. And even this still depends on these terms: relapsing MS, secondary and primary MS, and then this area here is called degenerative disease or lack of adequate repair as you get older. An alternative way of looking at this is one that Gavin developed, and a more overall complete idea of what's happening with multiple sclerosis. But you'll see here that I'm not looking at where progressive MS or secondary progressive MS is. I'm looking at the other end, at the beginning of this disease, before it's diagnosed. So this is, I think, really important because it indicates there's a disease process which is not manifest by relapses or overt focal disability, but that there is a process underfoot. We don't know exactly what it is, but it's important to know that it's a much more broadly spread disease in terms of time. This is shown in this study of radiologically isolated syndrome. The group that have gathered a registry of these patients, and at 10 years, 50% of them have actually converted to clinical MS. So there's a great argument as to whether these people should be offered treatment or not, and they weren't included in the latest diagnostic criteria because they didn't have clinical features and because MS is considered a clinical disease. So again, we're stuck in definitions and concepts which are really out of date. And the things which favoured conversion, there were 4 of them: age less than 37, oligoclonal bands in the CSF, and spinal cord and posterior fossa T2 lesions all indicated that the patients were going to become symptomatic earlier. Here's a little bit on this prodrome, a recent study that was presented at ECTRIMS, which confirmed an earlier study from Ruth Ann Marry and Helen Tremlett, which showed that patients visited their physician or neurologist for a number of other symptoms such as disturbance of skin sensation, visual disturbances, dizziness, giddiness, up to 5 years before they actually became symptomatic. Here's the study that Gabrielle referred to earlier also, a really, really interesting study. Only 60 cases, nested case control study among the US military personnel, but here's their 6 year prior to developing symptoms. Here's their neurofilament level elevated over the controls, and it gets greater in the year prior to their conversion to clinically expressed multiple sclerosis. And here we are showing that a bit more overtly. 1 year after they've converted, their neurofilament level is even higher. So although neurofilaments may have some problems in their use and how we interpret them, this is fairly clear that there is an underlying disease process well ahead of clinical expression. So, are progressive phenotypes useful? Well, I think only insofar as they illustrate what must change. They segregate treatments based on clinical phenotype. They restrict the flexibility that the evolving understanding of the disease pathogenesis and people with multiple sclerosis requires. They prevent treatments from targeting the underlying pathogenetic mechanisms of worsening neurological function, and they condemn those with core dysfunction that have said they are not eligible to disease to have worsening cognitive and upper limb function. I can skip this slide, and I just now want to turn to treatment, but before I do so, just to touch on what are the thought to be, what are the major causes contributing to progressive multiple sclerosis. So focal inflammation and the smouldering plaques, diffuse inflammation at microglial level, autoproliferation, a really important study by Roland Martin, which showed that memory B cells activate brain-homing autoreactive T cells. The cortical disease and the cortical lesions, which Gabriel so well illustrated, and these extralymphatic follicles within the meninges. Gavin commented on the ageing effect. So I've put ageing and comorbidities here, but this is looking at telomeric length, leukocyte telomere length, and it correlates, shorter lengths correlated with higher EDSS and greater brain volume loss, both at the entry to the study and over a 10-year period. And then we have all the secondary effects which we know most of, but there'll be others as well, but persistent demyelination resulting in increased energy requirements to conduct impulses, leading to mitochondrial mutations and axonal degeneration, energy failure, length-dependent axonal loss are probably all into this area here as well. What we don't know is what are the relative contributions of any of these, and that's a really important question in terms of targeting treatments. So going back to natural history, it came up earlier about the difference between secondary progression and primary progression. They follow the same course once they enter this so-called progressive phase, that is with increasing disability without obvious relapse, both primary progressive and secondary progressive. But also, if you look more carefully, older age at relapsing and remitting onset, their risk of going to secondary progressive MS is something like double or triple the risk if you're in the 40 to 50 age group compared to 20-year-olds. And the younger age you are at secondary progressive onset, the shorter the time to disability level 6, that is a cane or a walking stick, and on to 8. So this suggests in an untreated group that there's a combination of disease burden and ageing contributing to progression. And the important area that's now being recognised, as Gabriel mentioned, was the number of cortical lesions. So this is a really good study from Dr. Scalfari and his group. So if you have no cortical lesions at the time of diagnosis, your chances of going to secondary progressive MS over 10 years is virtually zero. But if you have 8 or more, then it's very high. And similarly for sustained disability. So cortical lesions are probably an unrecognised, up until now, important process and driver of cognitive decline and progression generally. So what are the lessons that we can learn from highly effective disease-modifying treatments? What do patients think the goals are? Do they just want the disease inhibited, or do they want a cure? Clearly they want that, but they'll settle for this or this, most of them. They don't really want this. So these are a series of studies reported in later stages of the disease showing that treatment at that stage still brings benefit. So this is Danish registry data comparing highly effective and moderately effective disease-modifying therapies, showing a benefit for highly effective DMTs. Here's a group of patients who changed from natalizumab to alemtuzumab or fingolimod. Alemtuzumab in green, fingolimod in blue. Clearly alemtuzumab is better for these patients who are later stage diseases, patients, not early patients, not at diagnosis. So there is benefit there. Here's another very good study produced in 2017 looking at changing in EDSS epochs from 3 to 6, 4 to 6, or 6 to 6.5. This graph here deals with the 6 to 6.5 group, but what it shows is that lower relapse rates and more time on highly effective therapy after reaching these steps, and particularly even getting to 6, is associated with a decreased risk of accumulating further disability. So again, even at 6, you can get benefit by treating them with highly effective therapies. So this has led to a change in how we term what we talk about in terms of treatment programs. So this is induction and one treatment. This is induction with repeated top-ups, and this is, if you like, the best way of looking at natalizumab. But the order are stem cell transplants, alemtuzumab, cladribine, which we've just heard about. I don't think anybody uses mitoxantrone and cyclophosphamide at the present time, thank goodness. But anti-B cell therapy is next there, and we're probably going to hear, well, we are hearing a lot more about it. So let's have a look at the benefit of early treatment compared to later treatment. This is a very good study looking at early intensive therapy versus escalation approaches in patients with an elevated EDSS anyway, and what happens over 5 years to the change in EDSS. And the secondary outcome was the time to sustained accumulated disability. So the patients on early intensive therapy did much better than the escalating therapy, and even those who went from escalating therapy to intensive therapy did not catch up, did not benefit by anywhere near the same amount as those that had had early intensive therapy from the beginning. We've heard a little bit about alemtuzumab and long-term effects. Here's the long-term follow-up data for the CARE-MS1 and CARE-MS2. This is looking at brain volumes. So the brain volume normalised quite rapidly after 2 years early on, but then maintained that over time. Those that did not start on alemtuzumab to begin with in CARE-MS1 managed to get close to the same as those that did start on alemtuzumab by 9 years. But those that had had previous disease, they were already on an interferon or an injectable, failed that and went into CARE-MS2. They never caught up. So again, early injury is going to carry on through the lifetime of the patient, even though you can get benefit by intervening with highly effective therapy later in the disease process. And similarly in the CARE-MS2 patients, clinical outcomes, annualized relapses fell and stayed low, and stable or improved EDSS scores remained remarkably stable without any additional therapy for out to 8 years. But as has been commented in discussion earlier today, we probably won't know the full answer to this for a lot longer yet. But it's very, very encouraging if you have MS yourself to see that this sort of effect is available to you. So, the treatment, just looking quickly at anti-inflammatory efficacy of these drugs, I won't spend too much time because they've all been touched on already, and then some potential adjunctive therapies. What is clear is that the evidence suggests that early treatment with progressive MS, and I hesitate to use the term progressive because I don't agree with that thing, I'd like smouldering MS or worsening MS, with highly effective disease-modifying therapies follows the same trends as we've seen in relapsing MS. Here's the Oratorio study that you're familiar with, a 24% improvement over placebo, and the primary outcome was 12-week confirmed disability of progression, but it was sustained also for the 24-week confirmed disability progression measure, and showed a similar improvement of ocrelizumab over placebo. And that's these two here, but in the 25-foot timed, 25-timed foot walk, there was a 29% reduction in that speed in those patients, improvement of ocrelizumab over placebo in those patients treated with ocrelizumab. The other endpoints did show whole brain volume change as well. So this was the first time that any agent had been shown in primary progressive MS to have altered the disease course, a very important finding. It gave heart to everybody, I must say. Later studies, or follow-up studies on extension, here's the extension in the Oratorio study, looking at the time to go to a wheelchair. So if you were in the early part of that study and you got treated from the beginning, you ended up at not too long into the disease with a 42% advantage over those who didn't get ocrelizumab to begin with. So they are 2 years behind before they start, and they're out there. So they go faster, more of them go into wheelchairs than those that get treated from the beginning. Just to touch on ofatumumab, I'm sure we're going to hear more about this, but this is again illustrating the intense interest in targeting B cells and probably targeting a small group of those B cells. But you can see, as was seen before, that the relapses and MRI changes were quite dramatic. And as Gavin said, there is a disconnect between these in terms of what the underlying pathology may be in this condition. EXPAND, which is a siponimod trial, showed a 26% risk reduction against placebo in so-called secondary progressive MS. And I should mention that both these trials, EXPAND and Oratorio, had patients with inflammatory disease, so-called inflammatory disease, that is relapses or positive gadolinium enhancing, positive enhancing lesions when they entered. This is the other parameters. It was of benefit in all those other subgroups pre-specified. Klaus has dealt with cladribine, which you know is an analogue of deoxyadenosine, and depending on the ratio of CDK versus 5' nucleotidase, these cells are susceptible, and it removes those, but spares, relatively speaking, monocytes. And with very little additional extra data, and this I think was an important thing to see, the FDA granted cladribine use in progressive MS as well as relapsing MS. I think they are beginning to realise, regulators are beginning to realise, that they have not done people with MS a service the way they have been so restrictive. So I thought this was a really important thing to have happen, but you can see that those with EDSS greater than 3 behave the same as those with EDSS less than 3 in terms of improvement. Natalizumab, we've heard, was originally announced by Biogen that it had failed its its primary endpoint target in the ASCEND trial, looking at the effect of it in progressive MS, but with the 9-hole peg test, as Klaus showed, that was very positive, and it probably drove the composite result as well. So what about these other potential treatments which may be used as adjunctive therapies? There's a number here. There's many others as well in the pipeline. The Progressive MS Alliance is active in this area, and Fran Quintana has just had a paper accepted for publication in Cell, looking at miglustat, a drug which has been used for Gaucher's disease and Niemann-Pick disease, but it looks as though it will be promising to use in MS because of its effect on the innate immune system. Biotin, a surprisingly positive result in its phase 2, is about to complete its phase 3 study, and we'll look forward to that with interest. Lipoic acid, 68% reduction in the annualized brain volume change, promising, but a small study. Ibudilast we've seen already, but there was a 48% slowing the rate of atrophy, so that is of interest. The anomaly is there was no change in the serum neurofilaments light results, but nevertheless worth pursuing, and we hope that there is a phase 3 study in the offing for that. This is simvastatin in high dose, as also mentioned recently, quite a good result for the phase 2 trial. The phase 3 is underway or almost halfway collected by that, but some 28 UK sites are involved, run by Jeremy Chatterway. And so there is a lot of potential to add to what we already use for patients with progressive MS, or what I would like to see us use more in a larger number for patients with so-called progressive MS. So what have we got so far? We've got phase 3 trial evidence of anti-inflammatory medication, ocrelizumab with oratorio, siponimod with expand, cladribine with onwards and clarity, and hopefully chariot. We've got a re-evaluation of natalizumab in the ASCEND trial, and people are now looking at hands, as Roche are doing with oratorio hand, and with cognitive function. We've got a lot more real-world registry data becoming available to us. MS base is something like 40,000 patients now, with relatively good data, even though it may not be as detailed as we would like. We've got phase 2 trial evidence for biotin, lipoic acid, ibudilast, simvastatin, and I think we do have a better understanding that if we limit early inflammatory injury in all MS, and we can deal with the ageing and comorbidity side of things, and we can tackle cortical lesions, we will be able to work out which of these are contributing most in individual patients. At the moment, we're going to have to try and apply treatments or mitigation strategies for all of these, but we don't know which one's the most important. We have potential biomarkers. There are problems with serum neurofilament light, but it's almost ready to be involved in progressive MS trials. So what do we need? We need improved disease detection early on in the disease process, and we need to be able to treat disease in all areas by suppressing it, using valid biomarkers, and on the basis of a better disease conceptual paradigm. I don't think we have that. We've been stuck in this problem based on clinical phenotypes, evidence-based medicine, and regulators saying how we should use drugs when they don't treat patients. It's been a real bind, and we've got to break out of it. So we have to apply the accumulating registry data more effectively, perhaps use proof of concept enriched trials to distinguish active axonal injury from age-related axonal attrition in patients with worsening. So just to conclude, these are these two things. This is what is believed to be the current concept of this disease process. I think it's outdated also. It still depends on phenotypes. This one here is more real, and this one of Gavin's, which I modified. So the questions are that if it's a disease process and it begins a lot earlier before it becomes symptomatic, and the pathophysiology is a continuum with age-related clinical expression of progression, should we continue to treat according to clinical phenotypes and difficult to define transitions? How difficult is it to define from patients when they enter so-called secondary progressive MS? And we shouldn't be forced to use these treatments according to the concepts of regulators and the adherence to evidence-based medicine. I think we probably should, this is a question, should we not develop a new perspective of the disease as inflammatory with a range of expressions, focal relapses through to small meningocortical lesions which accumulate over time, the whole process being at one, or it may be changing emphasis with time, we don't know that, but certainly, and there's no doubt that individual patients will have different expressions, but the overall process is going to be the same, perhaps just differing in terms of emphasis and temporal profile. So therefore, shouldn't we use more powerful and effective anti-inflammatories in an induction and immune reconstruction paradigm and add the adjunctive therapies as they become available for all MS where there is function to preserve? Thank you.